Hello, and a very warm welcome to everyone who is attending and participating. This is again yet another FRCR 2B team mock Viva session. We are very thankful to our new set of volunteers here who will be doing the Viva session today. So in the first set, we have Dr. Manu who will be examining Dr. Wala. Dr. Manu and Dr. Wala, the screen is yours.
Yes, hello.
Yeah, we can hear you, Wala.
Okay.
Manu, you can start. Manu, we can't hear you.
Am I audible now?
Yes, you are audible. It's perfect.
Okay.
Go ahead.
Okay, so this is the first case.
Okay, 60 years old man.
With dyspnea.
Okay. Frontal chest radiograph for mature skeletal adult patient showing mild enlarged heart shadow, prominent post-hilar shadow with upper loop blood diversion, bilateral asymmetrical perihilar diffuse ground glass opacification, evidence of interstitial radicular thickening with the short curved P line related to cross-tophonic angle in both sides, more prominent on the right side. Evidence of pacemaker with its tip in uni-lead pacemaker with its tip in the normal position. So in summary, there is a finding of chronic heart failure. I would like to refer the patient to referring physician on inform about the finding, and I'd like to compare with any previous image. I recommend to follow up the X-ray after heart treatment with diuretic treatment. Also, I recommend to do echocardiography.
Okay, fine. We'll go to the next case.
Frontal chest radiograph for mature skeletal adult patient. There is diffuse interstitial radicular thickening in both lung with no evidence of zonal predominant. The lung volume mild reduced in size. No evidence of mediastinal lymphadenopathy, no pleural effusion, no pneumothorax. So in summary, there is interstitial lung disease. My top diagnosis is interstitial lung fibrosis, interstitial pneumonia. I would like to assess the finding by CT chest, original CT chest, and compare with any previous image.
Is there any zonal predominance? You told there is no zonal predominance.
More at middle and lower lung zone. Lower, it's predominant lower lung fibrosis. And you can scroll the image. I will try to scroll.
I've given you the control.
Okay, CT chest, lung window, high resolution. There is bilateral, asymmetrical, interstitial reticular thickening, mainly subpleural with honeycomb cystic changes, mainly involving both lung predominant and lower lung loop. No evidence of pulmonary mass or suspicious nodule. The esophagus is mild dilated. So in summary, interstitial lung fibrosis with more affection of lower lung loop. In view of dilated esophagus, my top differential diagnosis is scleroderma. However, differential diagnosis could be idiopathic pulmonary fibrosis versus rheumatoid versus asbestosis, which is less likely as no evidence of calcified pleural plaque. So my top diagnosis is scleroderma. Okay. Frontal chest radiograph for mature skeletal adult patient showing first I see the left acromioclavicular joint I suspect is dislocated, or I would like to be confirmed by view in this area. Otherwise, the post-lung appear normal, no evidence of lung nodule. There is air fluid level in the right lung base. Would be
okay.
No evidence of pneumothorax, Could be pleural effusion, as there's obfuscation of costophrenic angle. Could be subpulmonary pleural effusion. I would like to confirm the finding by CT or versus ultrasound better ultrasound. The left costophrenic angle appear normal.
Any other findings?
I suspect there is widening superior mediastinum, evidence of right paratracheal shadowing.
That's not definite. Which are your review areas?
Lung apex, no evidence of pneumothorax.
Okay.
Post-hilar shadow appear normal. Retrocardiac area. I suspect there is right paravertebral opacity.
Yeah, go on.
Yes, I think there could be cardiac patient with mitral valve disease, double contour on the right cardiac border versus mediastinal mass, posterior mediastinal mass. I would like to compare with any previous image and ask about the history if the patient is cardiac patient. If not cardiac,
yes,
so
he's a known case of
cardiac.
Yeah, mitral valve disease.
Yes, this normal side heart shadow, but I see double contour right cardiac border, could be left atrial enlargement with displaying of carina and the right side pleural effusion.
What do you do with the patient?
I would like to compare with any previous image and there's this echocardiography.
Okay. Next case.
Frontal chest radiograph for mature scatter adult patient. I see there is diffuse ground glass opacification in both lung. Normal side heart shadow, no pleural effusion. According to the clinical history, if the patient has history of fever, could be
He has history of fever.
fever,
Yes.
could be interstitial pneumonia. If the patient has history of HIV, could be pneumocystis pneumoniae, pneumocystis carinii pneumonia. Different diagnosed pulmonary hemorrhage, but no history of trauma.
So what are your DDs from the X-ray?
I would recommend to do CT chest for better assessment and evaluation.
What are your provisional diagnosis from the radiograph?
Could be COVID-19 and this time as this image could be diffuse pulmonary pneumonia. Yes, in CT chest I see bilateral.
You can scroll if you.
Okay. I have problem with scroll. Okay, can scroll by yourself, please, doctors. Sorry. There's a bilateral asymmetrical perihilar diffuse ground glass opacification with multiple small cystic changes involving mainly upper and mid lung zone. If the patient has history of HIV, it could be pneumocystis pneumonia. Different diagnosis, pulmonary. Yes.
This patient is immunocompromised.
Yes. In case of immunocompromised, also pneumocystis pneumonia is my top different diagnosis.
And how will you manage?
I would refer the patient to referring physician and confirm the history of immunocompromised or HIV patient, and recommend the D-dimer level, assessment D-dimer level, and assess HIV history.
Okay, D-dimer level to rule out DVT and pulmonary embolism or pulmonary hemorrhage.
What? Sorry? What
you would do a D-dimer test. Is that what you told?
I think it. I don't know the number, but I think it tries with pneumocystis pneumonia. I'm not
Okay,
sure.
okay, fine. I will go to the next case.
Frontal chest radiograph for a young patient or for child. I see right side aortic arch, elevated right cardiac apex, prominent cardiac west. This finding gives the appearance of boot-shaped heart. My top differential diagnosis could be pathology. I am not sure. I am not sure.
Any other
I'm not
findings?
sure.
Any other findings that is in this one?
I see also the esophagus
This
is
patient-
dilated and with the air filled and blind in the distal blind distal end with air in the stomach, could be esophageal atresia.
Once again, stomach is dilated and
Dilated stomach is filled with air, and I see the esophagus is dilated or filled with air with the blind distal end. So it could be esophageal atresia with distal tracheoesophageal fistula. Also, I see the shape of heart could be abnormal, could be vectoral anomaly. I would like to refer the patient to referring physician and ask about the clinical history, assessed by echocardiography and ultrasound abdomen.
okay.
Frontal chest radiograph for a mature skeletal adult patient showing diffuse interstitial reticular thickening with small cystic changes, mainly involving mid and lower lung zone. No evidence of loss of lung volume. No medicinal lymphadenopathy, no broad effusion. So this interstitial lung disease with preserved lung volume could be interstitial cystic lung disease. I would like to assess the finding by CT.
Can you point out the cysts and
I see some thick wall, small cystic changes, and pulmonary nodules.
So, is there any particular terminology that you would like to add?
Involved middle and lower lung zone. Different diagnosis lymphangiomatosis, but less likely as there is evidence of pulmonary nodule, pulmonary Langerhans cell histiocytosis, neurofibromatosis.
Are cysts the most prominent finding in this radiograph?
No, pulmonary nodule more.
So what is the most?
So it could be pulmonary nodules scattered in post lung. If the patient has history of primary, it could be metastasis. Miliary nodules could be if the patient has history of fever or cough, could be miliary TB.
Okay. Any other finding that you see in this radiograph?
No evidence of medicinal lymphadenopathy, no pleural effusion. I would like to assess any finding for primary, no evidence of lytic or sclerotic bony lesion, no surgical clips.
So where would you look for the primary?
First, this patient, I think, male because no breast shadow. So I cannot assess the breast. No bony lesion, surgical clips, no surgical clips could be seen.
Okay, so which area would be assessed for the primary?
I assess the axilla, I assess the neck for thyroid and the parathyroid. I assess the bone, I assess any abnormality under the frame, any surgical clips.
Okay, so
actually I can't see any sign for primary.
Okay, so we'll do the CT.
Yes. Okay. Okay. In the X-ray, I suspect there is supraclavicular soft tissue shadowing. In CT, I see bilateral supraclavicular soft tissue mass lesion like represent the thyroid versus lymphadenopathy. I would like to see again. Yes, there's right thyroid loop soft tissue mass with lymph node on the other side, necrotic lymph node. With multiple pulmonary nodules. So in summary, there is a neoplastic process involving the thyroid malignancy with pulmonary metastasis. I'd like to refer the patient to referring physician and discuss the case with MDT. CT بقى chest abdomen pelvis يعني assist يعني distant metastasis.
Okay.
Dr. Manu and Dr. Vala, 15 minutes are up. Thank you.
Okay, thank you.
So, shall we go to the discussion? So
yes, please.
Vala, you have done exceedingly well. That's what I felt. In this radiograph, these are medial nodules, and the edge of the film you can see the soft tissue. So there is soft tissue involving the lower part of the neck. So that is a pointer towards the primary lesion in the thyroid gland.
Yes, okay.
Yeah, this is a case of tracheoesophageal fistula. And you have mentioned about the vactal anomalies that you look for. Anyway, in this image, the vertebra appears to be normal. There are no particular findings with regards to the skeletal system.
Regarding the heart, is okay?
The heart, yeah, you can say this is a boot-shaped heart with the tautology of Allen. This was a case of PCP. This is a non-specific finding in the radiograph, and you elicited the history of HIV positive. So in that case, the primary diagnosis becomes a PCP pneumonia. Here you have the typical findings with the perihelial opacity and fused cysts. This is a case of double heart shadow. There are two margins on the right side with splaying of carina and elevation of the bronchi. And there is some patchy opacities in the left lower zone, as well as some straightening of the left heart margin. So diagnosis correct is mitral valve disease, which is resulting in a enlarged left atrium.
I think there's also pleural effusion on the right side, or not?
Yes, there is some effusion on the right side as well. This is a case of ILD. You told about the esophageal dilatation. That I don't think there was a significant esophageal dilatation in this. Anyway, the finding was a typical UIP case.
Okay, idiopathic.
This was a case of acute pulmonary edema with the bat-wing appearance and upper lobe diversion, curly B lines, the interstitial edema in type.
The interstitial was alveolar or interstitial?
This is alveolar is a grade 3 variety of pulmonary edema. This is not its reached the alveolar. Okay.
Thank you very much, Dr. Manu, and thank you, Dr. Vala. It was a very good hot seat session. Only thing I would like to add that I think the one with the thyroid primary and the miliary metastases, we can always say that we would arrange an ultrasound guided biopsy of the thyroid, because we should always try to add the interventional radiology wherever we can. And as you said, referral to MTDs, referral to respiratory, in general terms. Your speed was very good of wrapping up the cases. That is what we need. Well, you can start sharing your screen in the meantime so that we save time. Just a few comments. And plus, what I liked about Vala, that she was wrapping up the cases. You know, the examiner should know that she's done with it. If anyone else has to add any comments, please go ahead. Otherwise, Vala can start examining Dr. Manu.
Vala is not saying the management unless asked. So you have to sum it up with saying the management. So that's what I felt. Otherwise, it's fine.
Okay.
So I think we can start.
Okay.
This is a frontal radiograph of chest of an adult patient, and this radiograph, the right apex shows there is a radioplasty involving the right apex. There is some amount of erosions of the adjacent ribs and as well as the rib crowding. Rest of the lung fields do not show any lesions. The cardiomediastinal margins and the costophrenic angles appear to be normal. So in this case, I'm suspecting a pancreas tumor of the right lung. The patient has to be further investigated using a CCT chest for confirmation of the diagnosis. And if it is pancreas tumor, the patient has to undergo a biopsy as well as a tumor tractor has to be activated, and the patient referred to chest MDT for the management.
Any other modality should done for this case?
CCT chest for confirmation of the diagnosis.
Yes.
And if it turns out to be a pancreas tumor, tumor tractor has to be activated.
Okay. The different diagnosis?
Since it's in the apical region, pulmonary tuberculosis is a possibility. But I suppose there is some rib erosion, so this is more likely to be a malignant neoplasm.
Next. This 20-year male come with cough.
So frontal radiograph just showing a cavitary lesion involving the left mid zone with shaggy margins. The cavity is thin-walled. There are a few ring-like shadows in the in bilateral mid zones. No other nodular lesions are noted. So in this case, no other pertinent findings with regards to the mediastinum or CP angle. The skeletal system also appears to be grossly within normal limits. So this, in this case, my principal diagnosis would be fiber cavitary lesion with bilateral bronchiectasis. So I suppose this patient, this is a case of pulmonary tuberculosis. My second differential diagnosis would be I would like to know the history of the patient, and if the patient is septic, I would suspect septic emboli.
What you will do next?
Next, I would do a CCT chest to confirm the diagnosis.
How confirm if this GP? How confirm CT chest? What you will see?
Pardon?
What you what expect you will see in CT chest if this TB?
TB would show the fibrocavitary changes, bronchiectasis, pulmonary fibrotic changes, then bilateral hilar adenopathy, maybe present multiple tiny calcific foci of granulomas.
Okay. Any other investigation you will do?
To confirm the TB, you can do you take bronchial washings and do AFB staining as well as culture.
Okay, next. Finish or still? Okay.
Okay.
Patient with shortness of breath.
Frontal radiograph of chest, which shows a reduction in of volume of right hemithorax. There is ipsilateral mediastinal shift with hyperexpansion of the left lung. The pulmonary vasculature on the right side, the pulmonary artery is also appears to be hyperplastic.
What's your different diagnosis?
My diagnosis would be hypoplasia of the right lung with this is possibly a case of Swyer-James syndrome with pulmonary hyperplasia as well as hyperplastic pulmonary vessels. Other differentials could be
if there is no history of chronic infection before.
There's no history of infection. There is hyper expansion as well on the left side.
Okay, what will you do next?
Next, I can do a CT chest for confirming the diagnosis, but I would like to know the history, whether he has had any but this is possibly a congenital
yes,
pulmonary hyperplasia.
Yes, okay. Next.
Frontal radiograph of chest of an adult patient showing multiple radiopacities in bilateral lung fields. These do not conform to any particular segmental distribution. So in this, these are plural calcifications.
Where is the plural calcification? Where is you see plural calcification?
This amorphous type of calcification in the left upper and mid zones. In addition to these findings, there is diffuse reticular shadows that are noted in bilateral lung fields. I would like to take my statement. These need not be a pleural calcification as such. So these are bilateral radiopacity in bilateral upper zones with diffuse reticular shadowing. So I would like to know if the patient has any occupational exposure to dust, silica dust. I would like to put it under pneumoconiosis, and the patient would require a CCT chest for confirmation of diagnosis. My first differential diagnosis would be pneumoconiosis with progressive massive fibrosis. Second differential would be
any different diagnosis you have?
This type of fibrosis can also occur in ankylosing spondylitis and sarcoidosis, but however, there are no significant lymph nodes seen at the hila.
Okay. Next.
This is a radiograph of chest, which the lung parenchyma appears to be grossly normal. No radiopacity are noted. I'm going through the review areas. The epices appear to be normal. There are no retrocardiac opacities. The cardiomediastinal margins also appear to be normal.
This is the 20-year male come with acute chest pain.
Okay. I'm looking for any causes of chest pain. There is no widening of the mediastinum as such.
Should check your review area.
The apex hyla, the supra and infradiaphragmatic margins, the all appears to be normal. In the upper abdomen, the splenic shadow is not well visualized. I would like to, in my usual practice, I would window the case and look at the skeletal system.
Yes. Any abnormality in the skeletal system?
And now, since the splenic shadow appears to be absent, I suspect hemoglobinopathy in this case, and I'm expecting depression of the vertebral end plates So there seems to be a H-shaped vertebra in the mid thoracic level.
Okay, what will you do next?
In addition, the right humeral head appears to be sclerotic.
Yes.
So this is a case of sickle cell anemia with acute chest syndrome and avascular necrosis of the humeral heads.
What you will do next?
Next, if the patient is already on under hematology care, if the patient is not on hematology care, I will refer to the hematologist for confirmation of the diagnosis. If he is he requires further blood transfusion for managing the acute chest syndrome. So this patient will be transferred to the hematology department for further management. A frontal radiograph of chest which show with endotracheal tube in situ. This the tube is reaching just up to the carina, which is slightly lower than the desired position. So the endotracheal tube has to be retracted by 2 or 3 centimeters.
Yes.
There is radioplasty involved in the left hemithorax with the ipsilateral mediastinal shift. There is some aeration of the left lower zone. So wheel-like opacity is noted in the left upper and mid zone. So this is possibly due to extension of the endotracheal tube across the carina into the right main bronchus. So retraction of the ET tube is would expand the left lung, and the collapse would be reversed. So,
yes. Any other abnormality you see?
Further, there could be another underlying hilar cause for the upper lung collapse on the left side. So this has to be investigated using a CCT thorax. In addition, there is a lucency involving the soft tissue of the right lateral chest wall.
No, okay, ignore it. What you will do next?
The ET tube has to be retracted, and any other underlying cause of the left upper lobe collapse has to be investigated.
What you will do?
CCT.
What you will do?
Using a CCT, you should look for a endobronchial carcinoid, which is causing the obstruction.
Next.
Vala, we
Last
have
case.
10 seconds.
So these are
Okay, this
multiple
last case. Okay.
Okay.
multiple embolization coils within bilateral lung fields, and
Multiple what?
okay, these are multiple radiopaque linear shadows. This is possibly arising from a previous as a result of a previous procedure. I would like to know whether he has had any procedure like vertebroplasty. If that is so,
Yes.
these are cement embolism,
Yes.
which have migrated from the vertebra to the pulmonary circulation. This patient would not need any other further evaluation, and
Yes,
can
patient
be kept
has
under follow-up.
previous vertebroplasty. Yes.
This,
Take another case or finish, Dr. Sabahat?
Finish. Time up.
Finish.
Time up.
This perfect. You say this cement embolization as the patient has history of vertebroplasty. This one you see endotracheal tube in the right main bronchus. This left upper loop lung collapse. So urgent informs the referring physician or emergency physician to pull up the tube upward. Also, the nasogastric tube is the abnormal position. You see the distal end outside the stomach.
yes,
But
yes.
also you see this one. This one you should pick up the vascular necrosis in posthumeral head quickly because it's very clear. Also, itchy shape appearance of vertebral body, sickle cell disease. In the management, you should hemoglobin electrophoresis. Also, I should do ultrasound to assess gallbladder stones and spleen and compare with any previous image. This one, you can say upper lobe lung fibrosis, different diagnosis, this mass-like lesion because of massive fibrosis, first possibility silicosis. First thing you should ask about the occupational history. Different diagnosis, bilateral bronchogenic carcinoma, but less likely, yani, you can do biopsy. This one, congenital.
Dr. Vala, we have lost your voice. We can't hear you, Dr. Vala.
Now it's okay now?
Yeah, it's okay. Can you please start the case again? This one?
Last one, this one or this?
No, this one. 3.
This one, a congenital absence of right pulmonary artery. You see here no pulmonary artery in the right side, in addition to small size right lung. Your different diagnosis should be McLeod syndrome. Do CT with contrast or MRI with contrast. Also, we can do perfusion and ventilation scan to differentiate between two situations.
Yes.
There was any previous image. This one, pulmonary TB. When I said to you what we will say in CT, you should say with endobronchial spread, tree and bud appearance. I should assess the size, the site of abscess should be TB posterior aspect or posterior segment of lower lung loop or apical segment of upper lung loop. Also assess lymph node. An investigation should assess the
Dr. Vala, we lost your voice again.
and cost tumors,
Good.
as you say, but in the investigation, you should say, I should assess by MRI to assess any invasion of brachial plexus. Also, I should assess by CT, PET CT to assess any distant metastasis or lymph node. This is the other two investigations should say. Other things are fine. Thank you.
Manu, you did excellently well. You saw around 7 cases, and the speed was very excellent. Like our expectation should be 2 minutes per case, but you did very well. But in the endotracheal tube malposition case, you should not tell endobronchial carcinoid as a DD. You just have to compare the previous endo before the intubation. There will be an X-ray, so you have to compare the previous X-ray. So that will be normal. There won't be any collapse. So that will confirm your diagnosis, and no further investigation is needed. You just have to inform the clinician and remove that or reposition that endotracheal tube. So don't tell unnecessary DDs. Okay.
Okay.
Yeah.
Okay. Thank you.
Thank you, Dr. Vala and Dr. Manu. Very good cases and very good hot seat representation. Thank you. Dr. Vala, if you can stop sharing, then Dr. Maha, you can start your screen sharing So Maha will be the examiner now, and Dr. Saneed will be the hot seat candidate.
Okay, everyone can see the screen.
Yes, we can.
Good evening, Dr. Saneed. You can start.
Can you hear me?
Yes, we can hear you
Yes,
now.
I can hear you.
Yeah, okay. This is a frontal radiograph chest of an adult patient. I can see bilateral abnormalities involving the upper and mid zones, predominantly in the left upper zone, where I can see multiple areas of fibrosis, volume loss, elevation of the bilateral hyla, and there is some tending of the diaphragm also. The cardiomediation counter appear normal. I can see some right paratracheal opacity also, but it can be due to projection. So I'm looking at the bones where I cannot see anything. I am also looking at the vertebrae for any abnormalities. So in summary, I can see some bilateral upper lobe fibrosis with some nodular. I'm not sure whether there are any nodular opacities. So I'll compare the previous images and we'll also look at the patient's history. So this can be due to tuberculosis or any sarcoidosis or any ankylosing spondylitis or any occupational lung disease. So if this patient had been to any endemic areas of TB and had previous TB, it would be like that. Or if he is an occupational exposure to any sand or something, it can be due to chronic silicosis. But I'm not seeing any nodular opacities, dense nodular opacities. And this patient needs further evaluation with the CT chest and comparison with the previous images, and also correlation with the clinical history. So these are the coronal images in lung window of this, and this confirms the findings of bilateral upper lobe fibrosis. I can also see some nodular opacities, and in my usual practice, I will see it in the mediastinal window and lung window, so a bone window. So I can see some dense nodular opacities also. There is a left side pleural effusion. Also, I can see some calcified mediastinal nodes, and there are some calcifications in the right side fibrous also. So this can be silicosis is my differential, and I will ask for any history of exposure to dust, and we'll refer this patient to the respiratory team, and we'll also inform the occupational disease team for further investigation and management.
Okay, so is there any finding that would suggest a definite diagnosis in this CT?
Dense nodules and progressive massive fibrosis bilateral.
Yes, and the calcification? Yes.
Yeah, calcified nodes.
Okay, next case.
So this is a frontal radiograph of chest of an adult patient, where I can see there is a retrocardiac linear dense opacity overlying the left side of the heart. So I'm also looking at the other areas of the lung, the cardiomediastinal border, the trachea looks fine, the bone, diaphragmatic area all looks fine. So this is a dense area, linear nodular type lesion in the retrocardiac area. So in my usual practice, I will compare the previous images to see whether it's a chronic finding, and also look at the clinical history, whether this patient is symptomatic or asymptomatic. And also, if there is a lateral view, I will do a lateral view to see the exact location of the lesion. So
actually, it was there in the previous imaging.
It was also, and if the patient is asymptomatic, then I'll also see whether it's a artifact, can be from the chest wall, or it can be from other areas also. So
so this patient is generally well. He's only going for preoperative screening, okay? But he's having some arrhythmia every now and then. So could this narrow your differentials?
Yeah, it can be calcification of a valve can be a differential. So I will refer this patient for an echocardiography and a cardiology review.
Okay.
It can be a calcification of a mitral valve because it's
excellent.
Yeah.
Yeah, excellent. Okay, so this is probably, as you mentioned, in the region of the mitral valve. Okay. Okay, your next case.
So this is a frontal radiograph of chest of an adult patient where I can see there is elevation of the right hemidiaphragm. I can also see there is some narrowing of the distal part of the trachea with some. I think there is some tracheal wall thickening also, and I cannot clearly see the right main bronchus. I can see the left main bronchus and hilar. So I'll compare the patient's clinical history, whether this patient is acutely unwell with dyspnea or any stridor. So
this patient is presenting with progressive dyspnea.
Yeah, if this patient is having progressive dyspnea and stridor, then this needs further evaluation to find out the cause of this tracheal narrowing and some volume loss in the right hemithorax. So I'll compare the previous images and will need to know whether it's an acute finding or a chronic finding, and we'll also refer this for a CT chest for further evaluation.
I'm sorry. You just mentioned that there is tapering of the trachea, right? Is there any other abnormality regarding the mediastinum?
Yeah, the cardiomediastinal, I'm looking at the cardiomediastinal contour. The aortic arch appears normal. I can see them right paratracheal soft tissue also. I think around the distal trachea, the soft tissue, there is thickening.
Yes, so great. Okay, so this patient went for a CT.
Yeah, these are the serial axial sections of CT, just in mediastinal window. The findings in the X-ray are confirmed with the narrowing of the trachea with surrounding soft tissue mass around the trachea with some heterogeneous enhancement, and that is causing this mass effect upon the great vessels.
Let me show you the X-ray.
That's also causing encasement of the vessels also. So this can be due to neoplastic process or any inflammatory process. It can be an atypical presentation of a lymphoma is a possibility, and it can also be due to so this patient needs referral to the respiratory team, and an EBUS endobronchial ultrasound guided biopsy is needed for further evaluation.
So what's your top differential, please?
I can think about lymphoma. I can think about any infectious chronic granulomatous disease or any. These are my two differentials: infective or neoplastic.
Okay. Okay, yes, this is your case.
So this is a frontal radiograph of chest of an adult patient. There is gross cardiomegaly. In my usual practice, I will measure the cardiothoracic ratio, and I can also see the hilar vessels through the left hilar vessels can be seen through the enlarged heart. So it cannot be a cardiomegaly because. And I cannot see the left heart border clearly. That left diaphragm is clearly seen, so it can be a mediastinal lesion. On localizing, so it should be either anterior or posterior mediastinum, but I'm not seeing the right aortic shadow also. If there is a lateral view available, I will compare the lateral view. I think it's an anterior mediastinal mass, and that is confirmed with the lateral view. So it can be an anterior mediastinal mass. It can be a thymoma or a lymphoma, but I am not seeing any calcification. So it can be a teratoma also. but I'll look at the patient's age and
Yes. Patient is an 11-year-old male and he's presenting with chest pain and shortness of breath.
in that case, it can be a teratoma, even though I'm not seeing any calcification, it can be fat component. So I will compare with any previous images if available, and also this patient needs further evaluation of the CT chest and referral to the chest physicians for further evaluation. So these are the findings in the X-ray are confirmed in this CT with a hypodense lesion, which is not enhancing in the anterior mediastinum, that is encasing the heart, that is causing mass effect, but there is no signs of any invasion or any aggressive features.
Mm-hmm.
So it can be a I'm not seeing any calcification, no fat component.
Mm-hmm.
So I'm also looking at any extension into the neck, and in the coronal view, that's not coming from the neck.
Yes.
So in a 11-year-old, it can be a germ cell tumor. Still, it can be a germ cell tumor.
Non-enhancing?
Or it can be a cystic or any like thymic cyst or something, thymic lesion, but it's very thymoma is very rare in this age group because it is usually seen in the adult age group.
Okay,
But
this patient had undergone several trials of drainage, and it recurs again. I'm just trying to give you a clue.
I didn't get you. The drainage of what?
He did several trials of drainage of this fluid-like structure, but however,
Maybe
back.
Yeah, it can be lymphangioma, lymphomatous malformation of the anterior mediastinum.
Yes. Okay. This is your next case.
Yeah, this is the frontal radiograph chest of an adult patient, where I can see diffuse abnormality involving the right hemithorax with the volume loss of the right hemithorax, with the elevation of the right dome of the diaphragm and tending of the diaphragm. There is some thickening of the horizontal fissure also. I can also see some pleural thickening with the nodular appearance of the pleural thickening on the right lateral chest wall. And I think there is some pleural thickening involving the mediastinal pleura also. So there is abnormality of the right side of the mediastinum with lobular appearance of lateral margins, and there is some mass effect upon the trachea also. So I'm not seeing any pleural calcifications. I think there is some calcification in the diaphragmatic pleura. I'm not sure. So there is some pleural effusion on the right side also. So I'm looking for any surgical clips or any signs of any surgery, and the left lung appear normal, or it can be hyperinflated. So in summary, I am seeing some diffuse abnormality with the frozen hemithorax like appearance of the right side. So it can be due to malignant mesothelioma or any adenocarcinoma metastasis. So if this patient is already a known case of malignancy, adenocarcinoma, it can be adenocarcinoma metastasis. Or if this patient,
what would you do next?
I'll discuss with the referring clinician and arrange for a CT of the chest, abdomen, and pelvis as a staging CT. So I can the findings in the X-ray are confirmed in this contrast enhanced mediastinal window of the chest. But I can see there is nodular pleural thickening involving the lateral wall, and I can also see there is a mass lesion involving the right side anterior mediastinum. So this is most likely an invasive thymoma with the invasion of the great vessels and the mediastinum. There is some pleural pericardial thickening, and there is some pleural thickening that is going down. And I am looking at the liver for any local invasion. I can see some focal lesions in the liver also. That's a liver metastasis. And I'm looking at the and there are some nodular enlarge. I can see some pericardial drop metastasis also. So this is an number. It's an invasive thymoma with a pericardial, pleural and pericardial and liver metastasis, and there is some involvement of the great vessels also. So this patient needs referral to the MDT, and also need further evaluation and biopsy and a referral to the oncologist.
Okay. Your next case.
So this is a frontal radiograph chest of an adult patient, where I can see there is some haziness or opacity airspace opacity involving the left mid perihilar region and also the lower zone. And there is some prominence or enlargement of the left hilum also. I cannot see the left heart border clearly. So it can be a consolidation of or collapse of lingula segment with some hilar. Can be due to compression or endobronchial lesion or any mass lesion. Or I will compare the previous images to know whether it's an acute or chronic finding, and also I will look at the patient's history, whether this patient is having any chronic symptoms or any smoker or any dyspnea or any other findings.
This is a 40-year-old male and is presenting with shortness of breath, and this was not seen before in his previous imaging.
Okay, then it can be caused by any mucus plug or any endobronchial or outside obstruction, causing any collapse of
Sorry to interrupt,
lung.
but the time is up. So if you
Okay,
can,
can we
Yes.
finish?
It can be left upper lobe collapse with the
Yes,
vein-like capacity.
excellent. What would you do next?
And this is Lufthrischel sign. So this in an adult patient, we need further evaluation with the CT chest abdomen and CT chest for further evaluation.
Yes.
Yeah, its time is already up. I can see the confirm the finding as left upper lobe collapse with I am looking for any cause like obstruction. I can see there is some obstruction of the there's a mass enhancing mass causing obstruction and collapse.
Yes.
So this patient needs referral to the MDT. Thank you.
Yes. Okay. Thank you so much. Okay. So I will just review the cases. So this was a case of on the plane radiograph, as you mentioned, it's a case of left upper lobe collapse, and that's an endobronchial lesion, as you can see here, and it's enhancing. Okay. Here is the lesion. Okay. So it's an enhancing mass lesion, and then just to know that you should go for a FDG PET if it's a well-differentiated tumor, then it will give you a negative finding, or if it's highly differentiated, then it will be, if it's under-differentiated, it would appear on PET. This patient went for PET and it did not, it didn't show any uptake, but however, it showed an uptake on dotatate, okay? So the other cases, I think you did excellent. This was a case of invasive thymoma, as you mentioned, and it was a mimic for mesothelioma. So that your main differential over here would be mesothelioma versus an invasive thymoma. Of course, it was diagnosed on the CT later. And this was a very good description because you could see the vascular markings, as you mentioned, and so it should not be, it's very deceiving that it could be a part of cardiomegaly. However, when you check on the, when you check that the vessels are seen through the mass, then you know that this is just something superimposed on the cardiac shadow. And then the non-enhancement pattern and the linear hypodensities over here, and the lack of any calcification of fat content, this would go, this turned out to be a case of a venolymphatic malformation, okay? You would just only mention the management over here. You would give the patient, first would go for a fine needle biopsy, and it was proven to be a lymphatic malformation. And then you could advise later on for sclerotherapy, but however, this patient, because as I told you, he had several times of failures of drainage and failures of sclerotherapy, so in the end, they went for excision. This was described very good as well, the attenuation within the trachea. And then on the CT, you should mention that, okay, so there are small flecks of calcification when you notice here on the CT, and this would raise the possibility of, can you recall the finding? It's a case of fibrosing mediastinitis. Okay, so you would raise the possibility that this patient is either an idiopathic process, or that he was exposed to TB, or he was exposed to histoplasmosis. Okay, so this was described really well. But the calcifications would have given you a hint about the fibrosing mediastinitis. This was also excellent. This is a case of mitral annulus calcification. Usually these patients, you can see that the cardiac shadow, as you mentioned in the description, is normal. because most of the patients of mitral annular calcification, they do not have a hemodynamic problem, such as in cases of mitral stenosis. It does not cause, so you just have to recognize the difference between mitral annular calcification and mitral leaflet calcification. This is usually associated with conduction defects and heart blocks. That's why I told you that this patient has occasional attacks of arrhythmia, okay? This was described really well as well, but I was just telling you that as I've heard it in the John Curtis session, that he mentioned that whenever the conglomerate masses are noted to be peripheral, they are not related to the pulmonary hyla, as you can see here. This would raise the possibility that this is a case of PMF due to silicosis. Okay, and of course you can see here the axial calcification as well within the mediastinal nodes. So thank you so much. This was an excellent hot seat. I hope I do well too. Okay.
Thank you very much.
Thank you so much, Dr. Maha. It was excellent cases as well.
Thank you so much. I'll just stop the share, right?
Yeah.
How many cases I saw? I didn't count.
I think you saw them all. Let me check. There were like 7. No, we saw six cases.
6 cases. Okay.
Yes, I think it was really good. Let me just remember, how do I stop the share? Give me a second. Yes, that's it.
Okay, are you ready?
Hopefully.
Okay. Sabat, please start the timer.
Once she starts talking.
Okay, shall I start?
Yeah.
Okay, so this is a frontal chest radiograph of an adult patient, which is showing a well-defined cavity, which is noted within the right lung region. It shows an air fluid level. It has a rather thin wall, no evidence of any nodularity. In view of this cavity, I would give a differential for a carcinoma of the lung or an inflammatory process, such as a lung abscess. I would ask about the clinical presentation of this patient. And
patient presented with a fever and chest pain.
Okay, so this would be more suggestive of a lung abscess with a fluid level. I would refer this patient for the pulmonary clinician, and would advise for a CT of the chest to delineate the inflammatory process.
Okay.
Okay, so this is a frontal chest radiograph of a female patient. I can see that there is, I think I can see that there are surgical clips related to the right axillary region. And however, I can see still the both breast shadows. This would raise the possibility that this patient has had a previous axillary clearance or surgery. The lung fields predominantly on the right appear to show some reticular with minute nodular distribution. In view of the presence of the surgical clips, I would think about lymphangitis carcinomatosa secondary to a previous history of breast cancer. I would refer this patient further to the MDT team, and I would ask for a CT of the chest, abdomen, and the pelvis for further.
Patient is already on MDT and already had a CT abdomen chest. Okay. So you just have to compare with the previous one. Okay.
Yes. Okay.
Okay. This is a 85-year-old female came with the chest pain to the ED.
85. Okay, so this is the frontal chest radiograph of an 85-year-old patient who's presenting with chest pain. The striking abnormality is the presence of rounded radiodense opacities, which are noted within the left upper lung field. I think that in view of the patient's age, I think this was, I would like to ask the patient if she had a previous tuberculous infection, because this was the mode of treatment like 50 years ago or something. So this is, I think,
She had previous tuberculosis.
So this is a picture of tuberculous plombage, if I remember well. There's also a flex of calcification in both hyla. Okay.
30-year-old male with a trauma.
Okay. So this is a supine chest radiograph of a 30-year-old male patient who's presenting with trauma. By reviewing the chest, I'm checking the ribs for any fractures. However, I cannot see any bony fractures regarding the thoracic cage. I do not see any evidence of pneumothorax in both lung fields. The cardiomediastinal contour is within average. I'm reviewing as well the bony structures. Yes, there is evidence of right shoulder joint dislocation. However, I'm not able to delineate any other.
So what will you do?
So I would refer this patient further to the orthopedic surgeon for further management of this dislocation.
And you will not take a shoulder X-ray?
Oh yes, I will. Of course, yes. Okay, so this is a routine follow-up. Patient is currently well. Okay, 65-year-old male patient. Okay, so this is a 65-year-old male patient with a frontal chest radiograph that is showing a marked enlargement of the cardiac shadow. Okay. I can see that there is a linear calcification that is noted along the left cardiac contour. This might be suggestive of ventricular calcification or ventricular aneurysm.
Yes.
However, okay, so okay, so this is. I would like to compare this X-ray with any previous X-rays to check if this cardiomegaly is present. I would also like this patient to be referred for an echocardiography, given that I can see both lung fields.
This patient is already in care of cardiothoracic surgeons and cardiologists. He's
already in cardio. Okay. So I would discuss the case further with the clinician.
He came for in the history. He came for a routine checkup in the cardiology. Followed for a post-operative.
Post-operative, but I'm not able to see. Okay. I can see that there are sternotomy sutures, if I can see well. So this patient might have gone for a cardiac surgery before, and this is why he's having this abnormal cardiac configuration. For example, he could have. I'm not sure. I'm not sure actually. Maybe cardiac transplant or something. I'm not sure.
Yes. Okay. Okay.
Okay, 35-year-old male patient who's presenting with shortness of breath since 4 days. Okay, this is a male patient. So this is a frontal chest radiograph of a 34-year-old patient who is presenting with shortness of breath. I can see that both lung fields are showing nodular shadows. Which is diffusely involving both lung zones. I would like to ask if this patient is acutely unwell. He's having shortness of breath, right?
Yeah, I already given the history.
Yes. So this is
he is not acutely unwell. Just minimal
shortness of breath, right? Yeah. Okay. So there is nodular shadows which are involving both lung fields diffusely, and both costophrenic angles are free. The cardiomediastinal contour is within average. The bony cage is normal. I'm not able to detect any pneumothorax or pneumomediastinum. And so this looks like a diffuse interstitial lung pattern. I would like to move on to a CT scan of the chest to be able to delineate the distribution.
What are the differentials before going to the CT?
Yes. So my differentials in this case would be, since it's a male patient, I would like to ask if he's a smoker. Might be a case of Langerhans cell histiocytosis, or I would like to exclude any any hypersensitivity pneumonitis if this patient is being exposed to any allergens, something like in his occupation. So
No occupational history.
okay. Fine. So my top differential would be a case of Langerhans cell histiocytosis regarding the CT.
He's not a smoker.
He is not a smoker. Okay. So it could be also a case of it's not coming into my mind at the moment. Okay, so maybe it's a case of chronic interstitial pneumonia, for example.
Is it an interstitial pattern or any alveolar pattern or something?
I think it's more like an alveolar pattern. I can see it's more in like an alveolar pattern.
So can you give? Can you change your DDs or something like that?
I'm trying to recall this, the alveolar pattern involvement. So it could be a case of the alveolar proteinosis, for example, anything which is infiltrating the alveoli, eosinophilic pneumonias.
Okay.
Okay, so the CTS confirms the presence of the interlobular septal thickening, which appears to be smooth, as well as the presence of the fluffy, the ground glass appearance, which is bilateral, perihilar, slight sparing of the subpleural area. And so it gives the classic appearance of the crazy paving pattern, which could be suggestive of pulmonary alveolar proteinosis. I would refer this patient further for the pulmonary team and ask for a bronchial lavage for further. Okay. So this is a frontal chest radiograph of an adult patient that is showing multiple variable sized, less than 1 centimeter, less than 5 millimeter nodules that are scattered all over both lung fields, and they appear to be slightly hyperdense. I can also see, we saw this case before, by the way. I can also see that there is
even if you see the case, you just have to.
Yes, I will follow the same system. Okay, so there is evidence of a soft tissue shadowing, which is noted at the lower cervical region, more obvious on the right side. So in view of this appearance with a neck mass, in addition to high density,
is it high density? Is it high density?
It's slightly, no, it's not. So with the presence of the nodular pattern of...
how will you describe these nodules?
I would describe them as miliary.
Okay, so what will you do?
I would refer this patient further for a CT of the neck, chest, abdomen, and pelvis for further evaluation. And also, I will ask for a neck ultrasound to rule out the presence of a thyroid malignancy, which would give this pattern of miliary shadow metastatic nodules in the lung.
Okay. This is also a 90-year-old female came to the ED with chest pain.
She must have chest pain. Okay, so this is a frontal chest radiograph which shows the severely deformed thoracic cage, and there is evidence of, I think, thoracotomy, something like that, done on the left side.
She had a surgery earlier when she was young.
So okay. So this is. So I would like to compare with the previous X-rays. However, Can I see the lateral view, please?
Okay, that's non-contributory. You can.
Mm.
So if I give you the lateral, you have to read it. If you don't know, then don't ask.
Okay. So this is. I'm not sure what kind of surgery or I'm not.
Yeah, it is showing to know whether you know the surgery. Okay, leave it.
Yes,
Okay.
please.
You have to. If you don't know, you just have to skip the film.
Yes, skip the case because I really don't know.
Hmm.
Okay, so this is a 24-year-old male patient who's febrile and septic. Okay, so that's the chest radiograph of the same patient who is febrile and septic. It's a frontal radiograph of the chest. Okay, so both lung fields appear to be unremarkable. I can see
they are doing the X-ray for a septic screen, just for finding out the septic screen. That's all.
Okay, there is slight blunting of the right costophrenic angle, and regarding the lung, the thoracic cage as well as the cardiomediastinal shadow, I would like to go through my review areas. Both lung apices are within are unremarkable. There is a small, I'm suspecting a small retrocardiac nodule.
Okay.
Yes, over here. Yes, a small retrocardiac nodule, which could be being present in the base of the lungs, and this patient appears to be septic. So I would raise the possibility of a septic cavity or septic nodule in the lung.
But that is not the source of sepsis. Do you have any other DDs?
Yes, it's a nodule within the lung, so I would go for further workup. I would go for a CT of the chest to determine the nature of this retrocardiac opacity.
Time's up.
Okay. Okay. The patient is a known case of melanoma, and it's a melanoma metastasis. So you correctly picked up that nodule. So it's a review area. So it's usually it's like a relatively normal film. So when you see a relatively normal film, don't get embarrassed. So go systematically, as you told, and you have to say what you are thinking. Like don't you did very well. Like you are saying what you are thinking and what you are looking at, like apex retrocardiac area, and there's a nodule, and so it's a solitary pulmonary nodule. So you have to tell like what will you do when you see a solitary pulmonary nodule, like like that. Okay, that was good. And this is this actually you will get such a film, like if you are presenting very well and you are picking all the cases, then the examiner will give you some cases like this to test you. So it's just as the examiner told you, like he had a surgery very long back. It's another like surgery for tuberculosis, that is a thoracoplasty done for tuberculosis. They will remove the lung and remove the rib and all. So just know whether you know that surgery. That's all. So you will not get these cases as the first case or the second case, but usually when you are seeing so many cases, more than 6-7 cases and all, then the examiner will give you to take a break. They will give you such cases. Okay. Okay, this you did very well because you already saw the case. So
but
even
these
if
nodules are slightly dense, it's calcified a little bit. Like if the origin is a papillary thyroid carcinoma, it could be a little bit calcified.
You have to use the term like miliary nodules because you can pick up each nodule. Miliary means with a forceps you can pick each nodule. So miliary nodule means you have to present like if this patient is acutely unwell, I'll think the possibility of a miliary tuberculosis like lethargy, weight loss and all. So if this patient is already known case of malignancy, I'll think the possibility of miliary metastasis. So in the most common cause of miliary metastasis is thyroid malignancy. I'm seeing a soft tissue swelling at the neck. So it can be a thyroid malignancy with metastasis. So I'll whatever the rest of the thing was fine. So your script was good, and then they will give you an ultrasound. Then they will give you. You haven't told about ultrasound guided biopsy again. So then they'll give you the ultrasound. You have to tell about ultrasound guided biopsy, referral to the MDT, and staging CT, chest, abdomen, and pelvis. That's all. And this case. Actually, these are mainly alveolar and interstitial both together, opacities are there. So you have to tell different scenarios, like if this patient is this is a non-specific finding because it's a DD case, differential case, so you cannot say a diagnosis straightforward. So you have to tell like the examiner is looking like how you are telling the differential diagnosis. Like it can be due to it can be due to typical and atypical infection, and if it is a immunocompromised, it can be due to atypical infection, or it can be due to pulmonary hemorrhage. So it can be due to pulmonary alveolar proteinosis, like that.
Yes.
You have to give all the DDs.
Yes.
Then they'll give you the CT. Then they are waiting for the buzzword that you already told, that crazy paving and typical. And they are also waiting for you to say that bronchoalveolar lavage and that periodic acid shift, something like that. So all you have to tell, like you have to keep the examiner sleeping. So don't make him awake and ask you questions. Okay.
Yes.
You did very well. Like you were saying all the findings, so that the examiner will feel comfortable. And it's a 65-year-old male, routine follow-up, currently well. So actually, this also you found out very well. Like there was a ventricular aneurysm, and because of that, they had a surgery. You can see the median sternotomy bias. And it was a heterotropic cardiac transplant. So
Yes.
this also actually very rare and very difficult case. You will not get these cases as first or second case. Maybe sometimes they will give you it as a last case or something. And finally, they will give you the clues, like he had a surgery, he is coming for a follow-up in the cardiac OP or cardiothoracic OP. Then you have to be familiar with this heterotropic cardiac transplant picture, like it's an on-mini.
Okay. Okay. Thank you so much.
And I think this was a trauma case, and that's a review area.
Yes.
So with the shoulder dislocation, so you have to arrange for a shoulder
corner of the film.
radiograph. It's a corner of the film.
Yes.
You have to refer to the ortho and arrange for a shoulder proper series, like AP, lateral, then Y view and all. So all the shoulder series you have to arrange and then refer to the orthopedicians.
Yes.
So then this was again as an on mini, but they are just checking whether you have seen it before, like and you know the procedure, like it's a thoracic plombage, usually done in 1950s, before 1950s, for the treatment of tuberculosis.
Yes.
So you can see the calcified lymph nodes also here. That was also previous history of tuberculosis. And here you correctly described there are surgical clips in the axilla with axillary clearance. There is some size difference between the breasts, so there is some breast saving surgery was done. And you can see there are curly B lines here. There are multiple curly B lines, interstitial thickening. So it's a lymphangitis carcinomatosis in a case of. So usually this case patient will be under care, already on the treatment. So you don't have to refer them again to the MDT and again do the CT chest and abdomen and all. So they are just coming for the follow-up. So you tell that you will compare the previous films. And if there is any recent change in symptoms, then you have to do a restaging CT and all. Like if you see anything new, like if there is a new node or a new lesion or something, I'll do further imaging, and just you have to compare the previous films.
Okay.
Okay. And this one you did well. It's a very thin-walled cavity with the fluid level. So you had to say, you don't ask the examiner like this patient, whether this patient is having fever and or something. You're asking me. So you have to tell your DDs as per the clinical scenario. Like you got to say, like if this patient is acutely unwell, or if this patient is having fever and signs of raised CRP and or WBC count and all, I'll think the possibility of lung abscess or infective etiology. Or if this patient is in one case of malignancy, or like that, you tell. Don't ask the examiner a direct question like whether this patient is having symptoms, fever, like that. That's not good.
Yes.
Okay?
Yes. Thank you so much, Dr. Sanid. Really, it was wonderful.
Dr. Sanid, there's a question. The chest X-ray of trauma, the one with shoulder dislocation, people are asking if there is pneumothorax on the left side. Is there deep sulcus sign? If you can just check, please.
That's not my X-ray, so I haven't checked.
No, the case which you had in your playlist. Yes, it's not your
okay. Actually, they're okay. They're looking for that shoulder dislocation. If that is said,
agreed.
the X-ray will go down.
Yeah.
So it's a supine film. So actually that is not included. That left CT angle is not. There is some pneumothorax maybe. I don't know.
No harm in saying it. If you say it, it's okay. If there is not, the examiner will say there is none.
Yeah, here also I don't know. Yeah, maybe. Yeah. Okay.
Okay, thank you so much, Dr. Sunij, Dr. Maha, excellent sessions. Dr. Leila, you are up next, and Dr. Vijaya, you are the next hot seat.
Okay, is it shared now? Yeah.
Yes, it's shared.
Okay, Dr. Vijaya.
Okay, I'm provided with the frontal chest radiograph of an adult. I can see a large, well-defined opacity involving the left upper zone with a sharp interface with the adjacent lung parenchyma. And there is calcific density noted within this lesion with the adjacent ribs showing erosion as well as mild separation. There is mass effect on the trachea, which is shifted to the right side a little. So, and about the rest of the lung fields, I'm not seeing any other nodular opacities. And other than a mild shift of mediastinum, the heart is normal in contour. And the rest of the bones are also appearing normal. So with the finding, the first possibility will be a large chest wall mass with erosion of the bones, which is protruding into the hemithorax. So with the calcification, I'll be thinking about a primary bone malignancy like chondrosarcoma from the rib. So I would like to look at the clinical details of the patient before getting into a diagnosis. And also, I would like to have a look at any prior imaging if available. And if none is available, and assuming this to be a malignant lesion, I would like to proceed with the CT, thorax, abdomen, and pelvis, and will alert the tumor tracker also.
Okay, very well. So next case.
I'm provided with the post-contrast images of thorax,
Would you like
axial
to scroll
section.
it? Would you like to scroll it, Dr. Vijaya?
Yeah.
Okay. I can't see your name.
Vijay can ask by
Yes.
going to the view option and ask for request remote control.
Did you receive it?
I already have this.
Dr. Vijaya, click once on your screen and then start scrolling.
I think you are controlling it now.
No, actually, I am not able to.
Okay.
So it's fine. Can you just scroll it for me? Okay, so the axial post-contrast images I can see some dependent opacities in the basal lungs, and there is mild pleural thickening also along the basal lungs.
Okay, this is a trauma patient, by the way.
Okay. And there is the upper rib on the right side was showing fracture with the fragment that's been one part that's displaced inside, which is probably lacerating the lung and pleura. And I would like to look at the bone window as well as lung window for better appreciation of the fractures, and also to look for any pneumothorax or lung contusion.
Mhm.
So the bone window provided shows a fracture of the left scapula, and fracture involving the multiple ribs on the left side.
Mhm.
So the fractures I can appreciate only in one location on the ribs. There is no flail. Okay, I would like to retract my statement. I can see the fractures anteriorly as well as posterolaterally. So there's possibility that there is a flail segment, and also some air pockets are seen within the pleural cavity on either side. So there is evidence of pneumothorax. And this surgical, the flail chest as well as the pneumothorax, surgical emergencies. So I would like to alert the referring clinician regarding the findings, and an emergency arrangement for an ICD insertion will also be made.
Mhm. So this patient did not have pneumothorax, so they put him under observation until day 7.
Okay. So this the just a frontal chest radiograph of the patient with trauma chest on day 7. So I can see multiple fractures involving the clavicle and ribs, and there is haziness of left costophrenic ankle as well as costophrenic ankle, which could be due to associated pleural effusion.
Okay.
And right hemidiaphragm is appearing elevated.
Mhm. So what happened between the first day CT, and this one?
So I would like to look at the clinical data of the patient, whether the patient is acutely, unwell even now, or whether he's getting better.
Yes, he's getting worse.
He's getting worse. Okay.
Yeah, see, there is sudden desaturation here.
Okay. There is and I'm looking at the mediastinal cardiomediastinal contour, which is appearing normal, and also on the left side there is haziness in the left mid and lower zone.
Okay.
Which could be due to the left pleural effusion and lung injury as a part of initial trauma. And also the left retrocardiac region is showing a triangular opacity, which could be the left lower lobe collapse. So I would like to go for a CT thorax again to look at these findings and to see if there is anything new from
Okay.
the previous CT.
Okay, fine. So next case.
Okay, I'm provided with frontal chest radiograph of an adult, and I can see a diffuse involvement of reticular shadows involving both lung fields with basal predominance, and
Okay.
the lung volume is appearing relatively preserved. And on the left side, the cardiac shadow is partially obscured. And so now I'm looking at the bones. The glenohumeral joints are appearing normal, and the acromioclavicular joints, there are some degenerative changes. Degenerative changes are seen in the vertebrae also. So other than that, I'm not seeing anything remarkable. So with the provided chest X-ray, my diagnosis will be my first concern will be interstitial lung disease of lower lobe predominance. Could be idiopathic pulmonary fibrosis, or it can be interstitial lung disease associated with collagen vascular disorders. So I would like to compare with any previous test radiographs if available, and also would like to look at the clinical details of the patient to see if he is she is on any in treatment for any chronic illness. And
Okay.
then I would like to proceed with the HRCT thorax.
Okay, fine. I'll keep the past history for the patient later.
Okay, this is the axial CT thorax in lung window. Shows multiple, shows diffuse involvement of both lungs with interstitial thickening, which is predominantly peripheral and subpleural in location. And no significant pleural thickening or pleural calcifications. No, okay, towards the basal lungs, I'm seeing early honeycombing in one or two locations. So this is a case of idiopathic pulmonary fibrosis. So I would like to look at the mediastinal window to see for any dilatation of the esophagus, and also I would like to look at the bone window to look for significant erosions.
Bone window is not available, but there are no erosions.
Okay. So this is with the provided images, my diagnosis will be interstitial lung disease of UIP pattern. There are some mediastinal lymph nodes, but no definite calcification noted within these nodes, and the nodes are appearing small volume. And some liver is appearing a bit hyperdense. So I would like to measure the density also to see if there is any mineral deposition or if there is any drug intake.
He is a
Because
cardiac
many,
patient.
okay. So the amiodarone and other drugs intake also should be considered as a possibility here, because there is interstitial lung disease of UIP pattern together with hyperdense liver.
Okay, so next case. I know this is a not so good image.
Okay, I'm provided with a scanogram of chest. And okay, so can see some radiodense opacities in the left lower zone, as well as with a shaggy diaphragmatic contour, and some opacities are seen in the right lower zone as well. And yeah, other than that, I'm not seeing any obvious abnormality in the lung fields, and the mediastinal contour is normal. So I would like to look at the CT images of the patient, and also I would like to know the clinical details of the patient.
So the
These are the
patient's
last
presenting.
15 seconds. So if you could wrap it up.
Okay.
Sorry.
Patient is presenting for the first time with dyspnea.
Okay, the lung window provided shows multiple patchy areas of consolidation as well as ground glassing involving the lower zones, and they are predominantly peripheral, and the lung volume is relatively maintained, and no obvious mediastinal lymph nodes that I could make out in the lung window. So with the provided with these findings, and if the patient is acutely unwell and is running fever, I'll be thinking about an atypical pneumonia as the first possibility. So other considerations are eosinophilic pneumonia or organizing pneumonia.
What would you do for the patients?
So I'll just get the lab parameters and also take a detailed medical history to get to a diagnosis. So in the present setting, I would like to ask for a COVID test also.
Very well.
So you can summarize, and because the next candidate also has to get the time, and give the feedback.
Okay, fine. So in summary, this basically this case was a cryptogenic organizing pneumonia. The basic differential here is for the reversal batwing appearance, which is mainly infections like COVID and atypical pneumonias mainly, cryptogenic organizing pneumonia and chronic eosinophilic pneumonia. So we'll just have to put this differential and how to execute each one of them, if possible.
Can I just add one thing? Like, if you're going to attend the exam, the next session and all, so when you're saying the COVID, then you are tell like, if this patient presented in this pandemic time, then I will think the possibility of COVID-19 pneumonia. Like that you have to tell, because it can be an old case. So like that you have to tell.
Yes, yes, very good. Okay.
Okay.
This case was an amiodarone lung toxicity and hepatotoxicity as well. The clue, you have described it very well. It is an UIP pattern, and you give the differential for the UIP pattern very well. And then when we reach here, the mediastinal window, we have to notice that the liver is hyperdense, although this is a non-enhanced scan. So this is the clue that this patient is having some kind of lung toxicity, and of course, amiodarone is the most common to give this picture, because amiodarone is the most common drug for this now.
Okay.
And this patient, he's a trauma patient, and if you notice here during the CT chest, there some problem happened. The first chest X-ray was not there, but the lungs anyway. The lungs were both almost equally ventilated, so they are of equal volume. But here the left lung is significantly reduced. And you mentioned the flail chest in the first and the CT scan. This is what happens, that when they left the patient on conservation, this flail segment of the chest wall started indrawing inside, leading to significant reduction in the left lung volume and increased desaturation for the patient. So this was urgently managed. It's called a stove in chest. Okay. And the first one, you described it perfectly well. This is a chondrosarcoma because of the calcifications. And this is why the patient presented. So this was the CT of the patient. Of course, we have to do a CT just to confirm the findings and confirm the extension. And here we also have an extension into the intervertebral foramen. That's why the patient also had an MRI study as well. But you described it, you picked it up very well on the chest X-ray.
Thank you very much, Dr. Leila and Dr. Vijaya. Very nice cases. Okay, so now we have